Hi, everybody. Welcome to Regional Pharmacy Journal Club. Can you hear us okay at the other site?
We can hear in Moncton fine.
Okay, thanks, Janet. So we're going to get started. Just wait for the room to quiet down here and thank God. So today I'd like to welcome Megan Harrison, who's our presenter for Journal Club. Megan is a former Moncton Pharmacy resident and now staff pharmacist at the St. John Regional and currently working on the CCU unit. So Megan's going to talk to us about CRAVE. You may have heard about it, may have not, but you'll get to learn about it in the next 30 minutes. Megan, I'll hand it over to you.
Hi, everyone. So I'm just going to jump right in. Okay, so today I'm going to be talking about CRAVE, or Cytisine is the generic name for it. And I'm just going to start off with a patient case, and so we'll talk a little bit about this patient, and then we'll return to them at the end. So we have MJ. He's a 56-year-old Caucasian male, and he's presented to you. He said his brother has recently had an MI, and this has kind of encouraged him to quit smoking or try to quit smoking again. His past medical history includes dyslipidemia, hypertension, he has type 2 diabetes. In terms of his smoking history, he currently smokes 2 packs per day and has done this essentially for the last 35 years. He's tried to quit 5 times over the last 35 years, and 2 of those times he tried to do it cold turkey. The other 2 he used nicotine replacement therapy, and then 1 time he did try bupropion or Zyban, and his longest quit attempt during those times was 6 months. So just a little background regarding smoking in Canada, because I feel like often we think with smoking it's so well known, all the terrible things about it, that maybe it's thought that a lot of people have quit, that there aren't as many smokers, especially that you're not able to smoke in so many places. You may not see it as commonly. But in 2017, Statistics Canada found that 16.2% of Canadians over the age, or 12 years or older, which would be about 5 million people, were either smoking daily or occasionally. It was found to be more common in males, so 19.1% of males and 13.4% of females. The least common age group was the younger age group, so ages 12 to 17, which is encouraging. And it was found that people who are in the lowest income households had higher rates of smoking than those who were in a higher income household. And then the pie chart really just breaks down the types of smokers. So 46.7% of Canadians were found to be lifetime abstainers, which essentially means that they've never smoked an entire cigarette in their entire life. And so then you can see 11.6% were daily smokers, and 4.6% were occasional smokers, so just saying that they smoked cigarettes occasionally. And then the rest kind of fell within either experimental smokers or former occasional or former daily smokers, so people who had been occasional or daily smokers but had since quit. And it is encouraging that the proportion of Canadians who are occasional or daily smokers has reduced since 2015, when it was 17.7%. But still 5 million Canadians is quite a large proportion. So currently in Canada, the main means of quitting smoking include going cold turkey in terms of pharmaceutical options. Going cold turkey, using nicotine replacement therapy, using bupropion or varenicline, so Zyban or Champix. And that just kind of outlines the average cost of a course of treatment for someone who didn't have any coverage for it. And that'll kind of come into play when we get talking about CRAVE. So just a few stats. So this was done by the Ontario Tobacco Research Unit. And so I just wanted to point out a few things. It's kind of hard to see, but this is just a poster that they came up with. And essentially, so 3 out of 5 smokers have the intention of quitting in the next 6 months. The average quit attempt is only 7 days, which was a lot lower than I had expected. And on average, a daily smoker does try to quit about once a year right now. So, but it takes the average smoker 30 quit attempts to successfully quit smoking. But the longer that so down in the bottom, the chances to improve does show that the longer you've gone without a cigarette, the better your chance of being successful of never smoking again. So this was just a summary of the effectiveness of different smoking cessation interventions. And basically it was just a network meta-analysis of all the latest Cochrane reviews comparing various interventions. And so what it's showing is the outcome was abstinence for at least 6 months in all studies that were analyzed during the network meta-analysis. So you can see there that when you compare NRT versus bupropion or varenicline, that it's statistically better than placebo for quitting smoking. Champix or varenicline is certainly the best, almost 3-fold better than placebo. Bupropion as well as and nicotine replacement therapy, when they were compared, they were the only 2 that didn't have a statistically significant difference between them. But Champix was shown to be statistically better than either of the other options. Okay, so Cytisine, so what we're going to talk about today. So what is it? It's a plant-based alkaloid that's found to be a member of the Leguminosae family. And basically, its mechanism of action is very similar to that of Champix or varenicline. So, but it is a natural health product. And it's been popular for smoking cessation in Eastern Europe since the 60s. So it's been around for a long time, but it's relatively new to us, and we'll talk a little bit about that. So most of the studies use the brand Tabex, which is found in Europe. But here, our brand that it's been, or how it's been branded, is Crave. So you can see those are just the structures of nicotine and cytisine comparatively. So they're similar. Like I said, it works very similar to Champix. So the half-life of it is about 4.8 hours, and the peak concentration tends to be 2 hours post-dose. So that'll kind of come into play when we look at the regimen of how it's used. So some of the previous literature, so there hasn't been a whole lot of well-designed studies. So probably the most prominent piece of previous literature to the paper that we're going to talk about today is this one here. It was published in 2011, and it's a placebo-controlled trial of Cytisine. It was a single-centered, randomized controlled trial, and it did show that Cytisine was more effective as a smoking cessation agent than placebo. So they looked at 12 months abstinence, and they found that 8.4% in the Cytisine group versus 2.4% in the placebo group abstained from smoking for 12 months. They did find an increase in side effects, very similarly to the paper that we're going to talk about today. But overall, they suggested that based on the affordability of Cytisine, that this was a reasonable option for patients to use for smoking cessation. There's been several systematic reviews that have also looked at Cytisine, but as I mentioned, there's not a lot. So outside of that study that I just had up, there were a few clinical trials, none of them controlled, and all of them in non-English journals that had been done almost 30 years ago. So there were really, prior to this one, there wasn't a lot to compare, but they essentially said the same thing as that article. So using kind of expected value, cytisine is anticipated to dominate Champix, and that, so in the first systematic review and economic evaluation, the reason that they're saying that cytisine may be a better option is essentially based on their economic evaluation of it. So we can talk about that a little later as well. And then the following systematic review found that it was an effective treatment for smoking cessation, and that it's comparable to the other options based on efficacy, and that the economic benefit is warrants kind of more studying. Okay, so this is the article we're going to talk about today. So it is from December of 2014. It's not overly new, and so it compares cytisine versus using nicotine replacement therapy. So it was a pragmatic, open-label, parallel group randomized control trial. It was a non-inferiority trial. It's done in New Zealand. They collected data for 2 years, so from March 2011 to February 2013, and the follow-up was 6 months. So basically, their claim of why this study is important is because it's comparing cytisine to active treatment, whereas only ever been compared to placebo in the past. So the research question. So they looked at adult patients, so you had to be at least 18 years or older, who were daily smokers and who were motivated to quit. So they recruited their patients through their New Zealand's national smoking cessation hotline, which was called Quitline. So you might have seen that in the paper. So they looked at cytisine, which was used a treatment course of 25 days. And then patients also received low-intensity telephone-delivered behavioral support. So basically what that was just 3 calls of about 10 to 15 minutes each over an 8-week period. So pretty low intensity. And then the comparator was nicotine replacement therapy. So patients used both patches as well as they had access to gum and or lozenges. And then they also received the same behavioral support. And then the outcome was continuous abstinence from smoking for a month. So that was their primary outcome. We'll talk about some of the secondary outcomes that they looked at as well. So why do we care? Like I said, the paper is a little bit older, but so cytisine was just recently marketed in Canada as Crave in August of 2017. So that's the guy who did it. So he's a pharmacist in Waterloo. And so, and as I mentioned, all the previous research has compared cytisine to placebo. And as we looked through the data, smoking remains a major health concern among Canadians. And so how it kind of came about here in St. John, I think that a lot of us ended up talking about it, was that one of the cardiologists had prescribed it to a patient as an outpatient, and we had a community pharmacy looking to see how they could acquire it. And the cardiologist is a big supporter of Crave and has had a lot of success, so he's kind of been talking about it, so we've all been talking about it, and so that's, I guess, why we care. So, as I mentioned, so it was a randomized control trial. 1,310 smokers were randomized through this Quitline. There were 655 in each group. The baseline characteristics were very evenly balanced. So 57% of both groups were female. The average age was 38 years old. The average number of cigarettes that they smoked daily was 19, so about a pack. And their cigarette dependence score was 5. So using the score, the dependence score that they use, 5 is like moderate. They're considered to be moderately dependent on smoking. Their exclusion criteria was mostly based off of contraindications to using smoking cessation products. So pregnant or breastfeeding women, if they were already taking a medication for smoking cessation or had been enrolled in another trial for smoking cessation, they had pheochromocytoma, blood pressure of over 150 over 100. If they had schizophrenia, so that came from the fact that cytisine is very similar to Champix in its mechanism, and so that's why those patients were excluded. And then if they'd had a cardiovascular event in the prior 2 weeks, they were excluded. Overall, not a huge list of exclusion criteria, I would say. So this was the cytisine, and this is the cytisine regimen that's used in all of the trials. And that's why I kind of talked a little bit about the pharmacokinetics, because in the first 3 days, they suggest using 1 tablet every 2 hours during waking hours, so up to 6 tablets, so assuming that you're awake for about 12 hours. Days 4 to 12, they use 1 tablet every 2.5 hours. Days 13 to 16, 1 tablet every 3 hours. 17 to 20, every 4 to 5 hours. And then days 21 to 25, every 6 hours. So it is a 25-day treatment course. So I don't know about you, but like this scares me. I can't imagine a lot of people being able to comply with taking something every 2 hours. But yeah, we can talk about that as well. Yeah.
Is that like 1 bottle?
Yeah, so there's 100 tablets is the full treatment course, and that's what the bottle would be. So, and yeah, it doesn't come in the same kind of pretty packaging, I guess, as something like Champix would. That kind of helps you lay it out better. It's just a bottle. So, and as you mentioned, all participants received the behavioral support. Nicotine replacement group, so they received vouchers and they had to go into the community pharmacies and redeem these vouchers. And there was a small cost to them as well to use the nicotine replacement. But they received vouchers for, as I mentioned, both the patches and the gum and the lozenges. And then, but the cytisine was provided free of cost and was actually couriered to the patients' houses, and that came from the drug company that was producing Tabex. And if you're on cytisine, so they were asked to reduce their smoking in the first 4 days and at their own pace, and then on day 5 was supposed to be technically their quit date. So they weren't supposed to smoke after that. And the participants in the cytisine group also did receive vouchers for nicotine replacement. And the thought for that was that, so the suggestion was that they weren't supposed to use those vouchers until they had completed their 25-day treatment course of the cytisine. And then if they still felt that they needed some additional support, they could use the nicotine replacement.
Was that intended to be along with, like after that?
Well, they wouldn't have been using cytisine anymore because it's only for the first 25 days.
Right.
Now, whether some of them would have used it when they were during the cytisine period of time, but the intention was that they wouldn't be using them concurrently. So outcome. So as I mentioned, the primary outcome was continuous abstinence from smoking for 1 month after their quit date. And then they had several, and so also of note is that, so it's self-reported abstinence. So they didn't do any like biochemical analysis to see if they had nicotine in their system. And part of that was because it included all of New Zealand, so trying to coordinate that would have been difficult, but also the patients receiving nicotine replacement therapy would have shown up positive regardless. So they just opted not to do that. So it was self-reported. And they were allowed to have a total of 5 cigarettes or less during that 1 month and still say that they had abstained. So I guess you have to keep that in mind. They did do these as secondary outcomes, these 7-day point prevalence for abstinence. And so in order to say that you had had 7 days of abstinence, you couldn't have even had a puff of your cigarette. So then they looked at continuous abstinence. So they did look up to 6 months after the quit date. They did self-reported adverse drug reactions. And so they were recorded during telephone follow-ups, but also were self-reported. And then at 1 week and 1 month, the Cytisine group were asked whether they would recommend Cytisine as a smoking cessation aid. So we're going to focus on the primary outcomes. We'll talk a bit about some of the secondary outcomes, but if there's any discussion at the end about the other things, we can certainly talk about them. So the primary outcome, so self-reported abstinence at 1 month, you can see that the Cytisine group had statistically significant higher percentage of abstinence at 1 month. So 40% of patients using Cytisine were still abstaining from smoking at that time versus 31% in the nicotine replacement therapy group. So it gives an NNT of 11. So the Cytisine group was significantly better at all time points for the secondary outcomes. Now, it was a non-inferiority trial protocol, but they did find superiority. So at 6 months, it was still significantly better. Cytisine was still significantly better than nicotine replacement therapy with an NNT of 14, which is pretty good. In terms of the subgroup analyses that they looked at, the only statistically significant difference was that they found that women they found that women had that were using Cytisine showed statistically significant, were more likely to abstain at 1 month compared to those using NRT, but they didn't see that when they looked at just the men subsection. So it's kind of interesting. It's also interesting to note, I guess, during the baseline characteristics, but it was 57% women, which is not typical of most trials looking at nicotine replacement therapy. So that was the only difference in the subgroup analysis. So side effects. So as I mentioned, they were self-reported, and overall, the number of side effects reported was higher in the Cytisine group versus the nicotine replacement therapy. So the most common side effects included nausea and vomiting. So you can see that the down on the bottom there is where they report them. But 30 participants in the Cytisine group versus 2 in the nicotine replacement therapy reported nausea and vomiting, and then sleep disorders was the other one, which I guess also not surprising given its mechanism of action and similarity to Champix. But when you look at the severity scores, so while there is more mild to moderate side effects in the Cytisine group, the severe group, it is more, but not statistically significant, or not, it wasn't statistically significant. Same with the serious adverse events. And like when you look at death, there was 1 death in each group. One of them was, in the Cytisine group, it was due to asphyxiation from alcohol, and in the NRT group was an MI. So I don't think you'd really necessarily attribute either of those to the therapy that they were prescribing. So I mean, it is of note though that so in the Cytisine group, 288 adverse effects were reported from 204 participants, and in the NRT group, 174 adverse events were reported by 134 people. So 31% in the Cytisine group and 20% in the nicotine replacement group.
Clarity on the otherwise medically important.
Yeah, so in the supplemental, it does kind of go through. It's basically anything that required a medical intervention or was thought to be of importance. So all of them are self-reported, but they all were reviewed by the researchers, and that's how they categorized them. Yeah, but it is vague. There's like the table's huge and the supplemental of all the different things that were included. So some study limitations. So they talk about some of the limitations at the end of the paper. But the researchers were aware of the treatment allocation. So it was an open label trial. So the patients knew, the participants knew that they were on cytisine. They knew if they were getting a nicotine replacement patch. They didn't try to blind it. And so that obviously inherently puts bias into things. So there could have been reporting bias, and so also with the adverse events. They were all self-reported. And the thought there for reporting bias is that patients are more familiar with nicotine replacement. Many of the patients who were randomized in the trial had previously had quit attempts. And so maybe they were more familiar with the side effects of nicotine replacement and kind of saw them as just being normal side effects that they might experience and might have been less likely to report them. But then there's also the thought that cytisine kind of had some novelty. It's a new product, and so maybe that may have affected kind of they wouldn't have likely had prior knowledge of cytisine, so some of its effectiveness might be explained by the novelty of it. So as I mentioned, verification of self-reported abstinence wasn't undertaken, so we don't really know that they had actually abstained. Now, there was a study. Now, the thought is that that wouldn't have been different between the two groups. So even if people were reporting that they were abstinent or had abstained, it probably would have, and hadn't, it probably would have been similar amongst the two groups.
Similar number of liars between.
Yeah, exactly. I was trying not to use the word liars, but yeah, that is what I was getting at. So, and then also thought that patients who are going to access a quit line or a smoking cessation helpline are probably more motivated to quit than necessarily your average smoker. And also the difference between access to treatment. So as I mentioned, those taking nicotine replacement, there was a small fee. They also had to go out to their community pharmacy in order to get it, whereas cytisine was delivered directly to the patient. So some of the strengths. So it was compared to active treatment. Now you could argue it wasn't compared to the best active treatment that's out there or the one that's most similar to it, but at least it was active treatment. It had broad entry criteria. I thought that all of the, I don't know, we can talk about it, but I thought all the exclusion criteria were fairly reasonable. The manufacturers, so they did provide the drug. They did provide cytisine free of cost, but they played no role in the design of the trial, the collection of the data, the interpretation, or the writing of the publication. So they used an intention to treat protocol, and they also did the per protocol analysis and found no difference between the two. The sample size was reasonably good, and their baseline characteristics were very similar amongst the two, both the ones that they report in the publication as well as in their supplementary. There really wasn't any difference between the two groups. So, does this study look at outcomes my patients care about? Were the patients in the study similar to my patients? So, for me, certainly on CCU, I see lots of people who smoke. We see it all, a large portion of our patients come in. So I think it's a really important outcome because we see the outcome of smoking all the time. Now, my patients in particular wouldn't have been included in this study because they excluded anyone who had had a cardiovascular event in the last 2 weeks. But so acutely, maybe we're not going to start prescribing cytisine to patients on the floor, but I think long term it is something that would be reasonable. And in terms of the benefits, the risks, the cost. So a lot of the previous literature, the systematic reviews talk about the cost. So it's about $55 for a 25-day treatment course. So it is much less expensive. Now, I mean, that doesn't take into account drug plans that are going to cover, your other options. This isn't, so it is an over-the-counter product. Anyone can go in and buy it. I would say most people aren't going in and purchasing it, yeah. So I mean that could play a big role. So, does anyone have any comments about that in terms of like applying the results to their patient population if they think it's an important study?
So Megan, 2 questions. So one, could they continue Cytisine beyond the 25 days?
So I think, let's see here. So some of the thought is that there needs to be further study to see what an extended course would look like. They all the studies currently have used the exact same regimen with the 25 days. But yeah, that is one of kind of the future things, I suppose.
I mean, like in CPU and stuff, you would like sometimes we want for like an NRT, right?
Mhm.
Combine it together.
Yeah.
Could you theoretically, if Cytisine were similar to brand clinical, they probably lose the desire to smoke. But is that an option? Can they take NRT if they want to?
So, well, I mean, these patients were given vouchers for NRT. So I think 4% of them was what ended up going and actually using the NRT vouchers. They didn't state when they went to use them, so I don't know necessarily if it overlapped if it would have overlapped with when they were taking the cytosine. But I guess theoretically you could use the two together. There's no one's ever looked at it. But, yeah. Any other comments?
I have a question. This sort of came up because you had calls from outside wondering where to procure this.
Mm-hmm.
Did we ever determine where to procure this?
Yes. So we have one pharmacy in St. John that has it.
Okay.
I don't know. They're the only ones I know that got it in.
So it's
But
not
so
like
they
we would be
contacted
referring people to like GNC or somewhere like that.
No.
Okay.
No. Yeah. No.
Because I'd rather not do that.
Yes. Shoppers Lansdowne. Yeah.
And Megan, so you don't have a lot of costs.
So okay. So are people going in and just getting it, or is it like under?
Primarily referral from cardiologists.
That's what. Yeah.
But then I work now.
Mm-hmm. Well, Dr. Stevenson's the one here who's been like the big push on it, and like he says he's had really good success.
I'm just curious what you said about we would be starting patients here. Is it just a study exclusion that post-MI, or is it something that's really similar to direct, like probably could, right?
Yeah, so we don't to be perfectly honest, immediately post-MI, we don't tend to use even Champax in those patients. They, like, nicotine replacement is certainly our go-to. But, I mean, yeah, I guess I was just referring to, like, the exclusion criteria for it. Now, I think, I guess it just hasn't been studied in that like, so acutely post-MI. Yeah.
Can Cessation and anything else secret formulary edition, or is this?
No, he's only been prescribing it, not to me anyway. No, I don't think so, not yet. But he's been doing it just in his outpatient population. Yeah.
So it just seems like a month as a magical cure from this is a little hard to take.
Mm-hmm.
So with Dr. Stevenson's experience, how long has he been doing this, and how is he expressing? So 1 month off smoking is nice, but 1 month off treatment, 1 month off. So what is he seeing? Like, how long is he seeing his patients?
Well, I mean, we only got it, I'd say he only had access to it in the fall, so it hasn't been that long. I think he's just found a lot of people who have tried it, it's reduced their cravings, so Yeah, the long term. So the placebo trial that was done prior to this did look at 12 months, but this study only looked up to 6. So it's, I mean, yeah, it's still arguable, I think, that whether or not. But considering the average quit attempt's only 7 days, you know, even a couple months is
True.
Pulse therapy.
pulse.
Month on, month off. But your quit times, like the percentage of people who stayed quit, dropped fairly dramatically in month 2, right?
Yes, yeah.
So, like.
Yeah, there you go. There, you could have your own trial. So your own trial.
There you go.
How long did they stay on Chapix? Because, you know, we prescribe it and send it out the door, but how long did they stay on it?
3 months, I believe is the,
Yeah.
So, yeah, so I guess that we've kind of talked about some of this, but there was another Cochrane systematic review that's come out since this trial, and they kind of mentioned like what Emily was saying, that it'd be interesting to know if using extended treatment or maybe, you know, multiple treatment courses, whether that would be helpful. And so, but I think it's promising. So I just kind of put the question out there of, you know, would you include this in your discussion with patients about smoking cessation, or are you still not sold? Anyone have any thoughts?
Megan, I just have a question. I don't know if you can hear me.
Yeah, I can hear you. Yeah.
So this is Rachel. So I found it very interesting that they didn't want to test anything aside from going with what the patient said, because I think in a lot of the varenicline trials they looked at, like they did breath tests for carbon monoxide. So, but obviously they didn't mention any, and there's nothing else coming, or that, you know, any studies that are going to look at, you know, a little bit firmer outcome.
Yeah, I agree. I mean, that's definitely a downside, like, kind of like Steve alluded to, like where the liars, you know, was it evenly distributed? And so they cite their main reason for not doing those tests as just being like the wide geographic area and the cost that it would have, like they basically that they didn't have like the funding to implement that. And
I think Dr. Stevenson should do a study.
Yeah. We'll get one started here. But no, you're right. I agree, Rachel. Yeah, for sure.
Megan,
You mentioned that they excluded patients with schizophrenia. Was there any other types of cancer?
That was the only.
That's it.
Yeah, that's it.
So where it works the same or similar to varenicline, the black box one, I think that's this, and it's over the counter.
And it's, yeah, so I mean, I think, now I don't know, to be perfectly honest, if it's behind the counter. Yeah. So, I mean, I think it's certainly a discussion to have with people. I would, I would think that it should certainly be.
Wasn't that one lifted to from medicine? Substance trials showed there's no increase in.
So, yeah. 3 minutes. Okay, 3 minutes. So I think that's pretty much it for what so just back to our patient case, you know, would this be a reasonable option for our patient? I mean, he's tried some other things. That's just some things that I thought about, you know, things I'd want to know more. What were like, how did he make out with these other treatment options? Financially, what is his situation? You know, does he have drug coverage? Is varenicline something he would consider trying? He hadn't tried it before. And the compliance, you know, do you think he's going to be able to take something every 2 hours, even for 3 days? I feel asking a lot. So, and they found that in the trial. So some of the reasons that they stopped were because of the treatment regimen, and compliance was fairly low. I think they only had 2 patients who actually took all 100 tablets of the cytisine during the treatment course. So, yeah, those were kind of And so the big points really, you know, I think that this does show that cytisine is a useful smoking cessation aid, and especially, and now it is available here to us. It's an affordable option for patients. The most common side effects were nausea, vomiting, and sleep disorders, and had trials of cytisine versus varenicline, you know, would shed more light, I guess, on what's our most effective option. Because really, if you look up the side effects of varenicline, the percentages of nausea, vomiting, sleep are very similar to that. So I think that wouldn't be necessarily the sticking point. It's more the efficacy. We don't really know. Yeah, and that was it. So, we're pretty much out of time, I think.
Thank you very much, Megan. And thanks for everybody joining us on Skype today. So if you guys could just send me your attendance either through fax or email, and I'll send out an evaluation for Megan later this afternoon. And I apologize if the Skype connection was bad. I'm going to get in touch with Facilicore about the connection in this room and see if we can fix it for next time, because I see that was going to the red zone at times. So hopefully you guys could hear okay. We'll be back in a couple of weeks for Grand Rounds, so we'll see you then.